Hello everybody, my name is Marianna Adamo from Brescia, Italy, and it's a pleasure to welcome you to this webinar on tricuspid regurgitation and heart failure with the preserved ejection fraction. So these two conditions are strictly related. As you know, the combination of these two conditions, as we'll see, is really common. And today we'll go a little bit more in details into the mechanisms and risk factors of HFpEF and TR, and we'll try to understand how to evaluate these patients with different modalities, echocardiography and right heart cath, and we'll get familiar with possible treatment options. So I will chair this webinar together with my chief, Marco Metra from Brescia, Italy, and we have a great panel of experts, a multidisciplinary team. So we'll have as speakers Marta Sigets, expert in imaging from Barcelona, Spain, and Carl Cresoia, who is online from Mainz, Germany, interventional cardiologist and heart failure specialist, and as discussants, Piotr Ponikowski, heart failure specialist from Poland, and Philip Lurs, interventional cardiologist from Germany. So let's interact with us using the chat. So Marta will help me to manage the questions and will try to address all your comments with the help of our experts. So without further delay, I would introduce the first speaker, Marco Metra, president of HFA and the chair of the last heart failure guidelines, who will talk about epidemiology, classification, and risk factors for HFpEF and TR. Please, Marco.
Thank you, Marianna. Thank you, everybody. Let me have the control of the screen. Okay, these are my disclosures. Okay. In the general population, actually, tricuspid regurgitation is the most frequent single valvular heart disease. These are data from a series of echocardiography data from United States, and you see that in this uncontrolled consecutive series of patients, tricuspid regurgitation was present in 7.1% of the patients, followed by mitral regurgitation, 6.5%, and aortic stenosis, 4.1%, and so on. And of course, the prevalence is also age-dependent for tricuspid regurgitation, even more than for the other valvular heart disease, with an almost exponential increase with aging. These are data from the second European registry on heart failure from the ESC, and these data are show the prevalence of isolated mitral regurgitation, isolated tricuspid regurgitation in orange, and combined MR and TR in the patients with heart failure. And what you see is that the patient with tricuspid regurgitation was present in 10% of the patients with HFpEF, heart failure and preserved ejection fraction, and another 8% had a combined disorder. It's also interesting to note that the patients with tricuspid regurgitation, either alone or combined with MR, were those with a worse outcome, much worse than that of the patients with isolated mitral regurgitation and without valvular disease as well. Now, what about heart failure with preserved ejection fraction? Tricuspid regurgitation is frequent, but heart failure with preserved ejection fraction, what we have learned in the last years is that this is increasing. And the reason for this is that coronary artery disease is less often a cause of heart failure because of better treatment with angioplasty, whereas we have an emerging number of conditions such as obesity, metabolic syndrome, chronic kidney disease, hypertension, aging itself, that are associated with heart failure and preserved ejection fraction. And this is now the most frequent cause of heart failure. And as you can see, we have a prevalence of HFpEF of about 1.5% of the general population in elderly subjects. And so this is a frequent condition. And so, when we think about the patients with tricuspid regurgitation, and you have here summarized the data from the four main registries of patients undergoing transcatheter treatment of TR, you see that the mean left ventricular ejection fraction of these patients was about 50%. I also want to notice, and we will come back to this, that atrial fibrillation was present in the vast majority of the patients. So when we have a patient with heart failure and preserved ejection fraction, and we know that these patients have adiposity, hypertension, age, elderly age, and CKD. And when we have a patient with atrial fibrillation, we have to think that this patient may have tricuspid regurgitation. And this is why we wrote this viewpoint for European Heart Journal. And this is why we had this figure. We show here that HFpEF and TR have many common conditions, such as atrial fibrillation, elderly age, female sex, and atrial myopathy. And here we have that HFpEF may be a cause of tricuspid regurgitation through postcapillary hypertension, pulmonary hypertension, through atrial disease, through exercise-induced increase in pulmonary pressure. But on the other hand, also the reverse is true, and tricuspid regurgitation may cause left ventricular diastolic dysfunction. And I know that Carl Patrick Cresoia will go deeper into this interaction. Here we remain with some epidemiology data, hoping that we can move to the next slide. And these are data from the Mayo Clinic based on the data from right heart catheterization, and we will see also data from Philip Lour's laboratory. And you see that patients with so-called isolated tricuspid regurgitation, so without left heart valve disease, without a reduced ejection fraction, you see that up to 74% of the patient had either mixed or postcapillary alone pulmonary hypertension. Here you have the follow-up of the patient with moderate and severe tricuspid regurgitation, and you see that a consistent proportion of patients develops diastolic dysfunction, indicated as DD. And you see that tricuspid regurgitation was also an independent prognostic factor for these patients. And in general, you see here that in the lower left corner, the tricuspid regurgitation is independent prognostic factor independently from the ejection fraction. And actually, if we look at the prognostic impact of TR, this is even larger, with a larger dissociation of the Kaplan-Meier curves in the patients with HFpEF compared to the patients with HFrEF. And what else? TR is also important for the treatment of atrial fibrillation. You will see that frequently the treatment of atrial fibrillation with pulmonary veins ablation is put first in the patients who have atrial fibrillation. But however, when the patient have a persistence of tricuspid regurgitation, or even if they are at baseline with severe, here called advanced TR, the patients are more likely to have a recurrency of the atrial fibrillation event. And this is published in ESC Heart Failure, a journal that we want to support. So what about what happens when we detect HFpEF? We have treatment of HFpEF, and SGLT2 inhibitors are indicated, as you will see. GLP-1 receptor agonist may have favorable effects because, for example, these drugs decrease blood volume, and this may help to decrease tricuspid regurgitation. But we don't have data in these settings. And therefore, and also MRAs and finerenone may be indicated. So to conclude, older age, female sex, HFpEF and atrial fibrillation are associated with a high prevalence and incidence of tricuspid regurgitation. TR remains an independent prognostic factor in these patients, and the impact of medical treatment of HFpEF for tricuspid regurgitation, differently from MR, is still unsettled. Thank you for your attention.
Thanks, Marco. Thank you very much. So there are no questions in the chat, so I would like to remind you to ask questions and take this occasion to interact with our experts. So meanwhile, I would ask to Piotr, who is a heart failure specialist. We have seen the typical clinical profile, the typical characteristics of these patients, but what is the typical clinical presentation in an outpatient clinic or in an emergency department, and do you use in your clinical practice scores to reach the diagnosis of HFpEF?
Well, great question, Mariana. Thank you very much. Marco always very elegantly summarizing the whole story as he did this time. So number one, yes, the scores are highly recommended for the initial diagnosis of HFpEF. Let me just say that there are two main scores. There are many. The one which may be a little bit more simplistic in a way, but it works well, is the American score with this H2FpEF, which is heavy hypertension. Then we have this typical risk factors as atrial fib, pulmonary hypertension, elderly patients, and elevated filling pressure. This is this American one. And then we have a very elegant document from Burkhard Piske, first author, subsequently followed by a exercise testing for HFpEF patients summary, when we more or less at the same kind of a several step approach evaluate underlying risk of the disease, again, with all the factors Marco so elegantly alluded to, patients who are elderly, obese, with hypertension, with atrial fib, and also with echo and ECG. And once we cannot exclude that in dyspneic patient, this dyspnea is of non-cardiac origin, and then we go for the next step, which is obviously consider HFpEF. Then we go for several other testing I'm sure we will be discussing. So Mariana, to make long story short, yes, the scores are very important. I would kindly refer you to two, American and European, but let me just give you one additional information. Professor Marco Metra and Mariana Adamo just recently published very elegant data from Italy on tricuspid regurgitation. Do I have 1 more minute?
Yeah, sure.
Okay, so they published this as an observational study from Italy, correct me because you are the lost authors, and they alluded to this population of nearly 700 patients, and they elegantly pointed out that now, according to the classification, we have a primary TR, which is mainly related to device-related tricuspid regurg. But if we take secondary tricuspid regurg, then we have mainly of atrial origin and ventricular origin. We are less familiar with this division in our everyday clinical practice, but reading the paper, it is pretty intriguing concept. So we are talking about atrial myopathy and right ventricular remodeling. And if you look at this paper, a few weeks ago published in the European Journal of Heart Failure, you will see a different clinical profiling. Patients with atrial tricuspid regurg taking phenotype, they are more likely women. If I am correct, there are about 50 or 60% in women versus only even more, about 80% of women in this population versus about 50% in those with ventricular TR. They were younger, but also very importantly, they were with less comorbidities with this atrial myopathy and with less symptoms. So looks like that there are two different kind of scenarios. And please consider that in both, atrial fibrillation was present in nearly 70 to 75% of everybody. So I would simply say, if I see the patient with a lot of comorbidities, with severe symptoms, if I grade the probability of HFpEF and examining them, I hear tricuspid regurg, then HFpEF is very, very likely, if not 100% likely scenario. And I would be a little bit reluctant to go further deep into the further assessment because as Marco said, I have armamentarium in my head. It would be my humble comment, and please challenge me if you have more questions.
Thank you very much, Piotr. Very comprehensive. Thanks also for mentioning the paper. So we have to move on with the next presentation delivered by Carl Patrick Cresoia, interventional cardiologist and heart failure specialist in Mainz, on mechanisms and pathophysiology of treating TR in HFpEF. Carl is really expert in right heart cath, and he also performs procedures on the tricuspid valve. Please, Carl.
Thank you very much for the kind introduction. And before I start, maybe I would invite you to think about the last patient with severe TR that you saw in your clinic and picture him or her in your head. And I bet when you think back, this patient presented with dyspnea. And this is something that was very interesting all the time for us, because when we as physiologists looked at the typical displays here from Netter, for example, TR is not usually described to go hand in hand with dyspnea, but this is what in everyday clinical practice our patients are showing. They show with TR and dyspnea. So why is that the case? And one possibility is that there's, and we've heard about this already, a large overlap between heart failure on the left side and tricuspid regurgitation. And this is especially the case with HFpEF. And we also know that TR is increasing with higher age. So, and this is also something that holds true for HFpEF. So a lot of our left-sided heart failure patients, they have dyspnea and TR, but what causes what? And this is something that was always very interesting for us, and it is quite challenging. We talked already about a bit about the scores, how to define HFpEF in those patients with preserved ejection fraction and tricuspid regurgitation. And this is some data that we have not published yet, where we looked at the fraction of patients undergoing T-tier, and we stratified them by their ejection fraction. And we can see that approximately 1/3 of those patients will have reduced ejection fractions, and 2/3 will have preserved ejection fraction. But do they have HFpEF? I mean, it's quite challenging to define this, right? Because a lot of those alterations that we expect from HFpEF patients, they will be present just by the coexistence of TR. And so how do we define HFpEF in those patients? And we as a hemodynamic group, we have a very easy approach. And we said we define it according to wedge pressures, because filling pressures are that sign, the clinical sign that causes dyspnea, the hallmark of HFpEF. And when we stratify our patients, we can in fact see that most of those patients that undergo T-tier, they have HFpEF, they have preserved ejection fraction, but also elevated filling pressures. However, there's also a smaller group with preserved ejection fraction, heart failure symptoms, and no elevated filling pressures. But that's a story for another day. So the thing is, when we talk about heart failure and TR, it's no way to go around the fact that both factors, TR and heart failure, they cause very similar things, both regards to backward and forward failure. We see reduced cardiac output in heart failure. We see it in TR. We see congestion of the kidneys, of the spleen, of the intestinal organs. So there's a very large overlap, and it's really hard to distinguish what is caused by TR and what is caused by heart failure. And we tried to look at this, and I will invite you to look with me at a case of a patient, a 70-year-old gentleman, which presented to our department some years ago right now, actually, but still one of my favorite cases, with typical signs of RV failure, high predicted operative mortality, AFib. We see secondary TR with, quite honestly, very large volumes. And one of the first things we did for this patient was assess his hemodynamics. And we can see that this patient has quite elevated PA systolic pressures, right? So this is a very impressive 65 systolic pressure. And we can see the typical hallmark on the right heart catheterization of the right atrium, where the curve form, the waveform, is almost not distinguishable from the right ventricle. We call this ventricularization. And we can see that this patient has massive TR. We see the RA pressure is 30 millimeters of mercury. And we can also see a typical sign when we let this patient inspirate. It's the Kussmaul sign, where we see a paradox increase in right atrial pressures during inspiration. And what we did with this patient is we performed a cardiac MRI, and this is already a very interesting observation. And please bear with me, this is a very special patient because he had a gigantic right ventricle. He was a very large man, almost 2 meters large. And we can see a massive right ventricle. And we can already in this video see one of the most important things that were within our observations. And we're going to talk about this in a second. But right now, stay with me that the RV is massively enlarged in this patient. And you can already see the paradoxical movement of the septum, where the RV is pushing the septum to the side. And this is the same patient. The only thing that distinguishes is 1 month and 1 clip, but to be honest, it's 3 clips. And this 2 videos already give away everything that we saw. And what we saw in this patient is that by reducing TR, we were able to significantly reduce the right ventricular volume overload. So the RV shrinks. And what's the second thing we can see this paradoxical movement of the septum. It goes away and the left ventricle becomes a bit rounder. And we believe that this is a very important mechanism in patients that present with preserved ejection fraction, elevated filling pressures, and TR. Because what we saw in this patient is obviously this is something we expect, right? When we treat the TR, we expect a reduction in right atrial pressure. The right atrial pressure curve also becomes more physiological, not ventricularizing. And so we already reduced backwards failure in this patient, right? But what was more interesting, we did some pressure volume loop analysis in this patient and in 19 others, and which within a study that we published. And what we saw is that when we looked at the left ventricle, immediately during the procedure, there was a rightward shift of the anti-diastolic pressure volume relationship. So this meant that despite an increase in left ventricular filling pressures did not go up, but remained preserved, or in this extreme case, they even went down. And this is super interesting and puzzling for us, because this should not be possible, right? Because the anti-diastolic pressure volume relationship, which is the dotted line left down, it is something that is dictated by myocardial properties. And by treating something on the right side, somehow those myocardial properties changed. This didn't make much sense at the beginning. But what we saw as one potential mechanism for the interaction of the LV and RV is that, and this is the pre-reading of this patient, simultaneously measuring the LV and RV, we saw that especially in the early filling phase, the RV diastolic, the early diastolic pressures were higher in these patients and found an equilibrium later in diastole. And this is very important because we believe that this is a typical patient which showed pericardial restraint as a mechanism for elevated filling pressures. This is the only reason why those patients can improve so fast, because their left ventricle is possibly not intrinsically sick, but the decrease in compliance and diastolic function arises through pericardial constraint, because we know that the pericardium is a limited space. And when the right ventricle takes up so much space, the left ventricular transmural pressure, which the LV needs to distend and open up and get his round shape, it's not sufficient to overcome the pressure which is put on by the right ventricle, which is quite proportional to the right atrial pressure. And we saw in this patient that the RA pressures were massive. And so what we saw, and this is the study showing all 20 patients, that this transmural pressure, when we treated TR, went up. So the left ventricle had more power to open up, and it became from its D-shaped sign more to a round physiological space. And what was very interesting for us to see is that the best predictor for improvement in left ventricular filling was the reduction of the right ventricular dimensions at the end of diastole. So the more space the RV gave up in the pericardial space, the more the left ventricle had space to distend and open up. Another factor that we saw is that this, and this is something we saw in the pressure curves at the beginning, is that this early change in the septal curvature that occurs at the beginning of the diastole, it is heavily correlated with the filling of the LV, especially the early filling, which is among the most important parts of the filling. So the better the septal curvature became, the more the LV was able to fill up earlier and start its diastole. And the best predictor for the change and improvement in the septal curvature was a reduction in early RV volume of overload. So that this reduction in early RV filling, which normalizes the septal movement, probably allows the left ventricle to fill up more physiologically and early. And we saw this in the patient at the primary endpoint, that the end-diastolic pressure-volume relationships shifted to the right in most patients. And what was especially interesting and what is really puzzling is all those patients we included, they had elevated filling pressures at the start of the procedure. But 33% of those patients at the end, they had normalized filling pressures, which was really puzzling and interesting for us. And this led us, and other groups we've seen this slide, to believe that there's really something like a TR HFpEF phenotype where increases in EDP cause pulmonary hypertension, right ventricular dysfunction, worsening TR, RV to LV interaction becomes worse, LV filling is restricted, and LV EDP increases. And when we thought about this at first, we thought that it must start with LV filling. But nowadays, we think you could join in on this vicious circle at any point. And when TR becomes so massive, it becomes a perpetuum mobile and just a vicious cycle which can be broken when we treat TR. So I would like to conclude that TTR increases left ventricular filling and without increasing end-diastolic pressures. This is due to a rightward shift of the end-diastolic pressure-volume relationship, which likely occurs due to two factors: an improvement in the early filling of the LV due to a more favorable movement of the septum, and due to the fact that the RV gives up space in the limited pericardial space, and the LV has more room to distend. So I'd like to postulate and discuss with you TR HFpEF, if we accept this as HFpEF at all, might be a causally treatable phenotype. And with this, I'm looking forward to a nice discussion. Thank you for listening to me.
Thank you. Thanks, Carl, for this excellent presentation and the fantastic clinical case. So I would ask Philip a more general question related to the initial evaluation of these patients. So, Philip, do we have to perform a right heart cath to all our patients with HFpEF and severe TR? And which parameters do we have to look at? Pulmonary hypertension, pulmonary pressures, cardiac output. Are there some cutoffs that you use in your clinical practice to make the indication to the intervention or to avoid the intervention because of risk of futility?
Yeah, thank you, Mariana. Very important question. And in short, I'd say yes, we should do a right heart cath in all of these patients. And obviously, there are some considerations about fertility, about benefits of treatment, about prognosis, but also we as treating physicians, we want to understand the disease. And you don't have to do it as thorough as Carl has demonstrated in this very particular study. But I think to understand the individual phenotype, some information from right heart cath is really necessary and extremely important. What are we looking for? Obviously, we look at pulmonary artery pressures, but we also want to put that into perspective and see what is the postcapillary contribution, what is the precapillary contribution, because what we have seen in numerous studies is that it's not so much about PA pressures, it's much more about how much there is left-sided increased filling pressures and how much of a precapillary component. And in short, it is not so much PA pressures. When there is only postcapillary pulmonary hypertension, then outcome and benefits and also symptomatic benefits seem to be much more pronounced, and patients seem to benefit much more than in those patients where there is, in addition to that, also a quite high and significant precapillary component. And I mean, you can imagine that differentiating between these different phenotypes of HFpEF TR, but in general of TR, phenotypes of TR, the additional information you get from right heart cath is extremely helpful. And this helps to judge the treatment benefits, it helps to consent the patients, and it also helps to predict how much the patient can expect benefits after the procedure.
Very useful. If I may, I'm wondering, here we start with a patient with TR, but we must also learn to start from the patients with HFpEF and look for TR, HFpEF and atrial fibrillation. And actually, I like the simplified diagnostic method by the Mayo Clinic Borlaug group. And they say essentially that we have just two, I am a simplifier, and they say that there are just two phenotypes. There is the obese phenotype and the phenotype with elderly and with atrial fibrillation. And these phenotypes frequently have pulmonary vascular disease, so they may have the precapillary component. And
well, Philip, I also remain a little bit skeptical in everyday clinical practice because we are seeing this from your. Well, we're doing not that many catheters as you are doing now. We are in a 2 or 3 projects, so we are doing this pretty often, but in HFpEF patients. But I entirely share Marco's views that to simplify and to propose to the broader audience the kind of a pathway where catheter is really needed for decision, not and then for the intervention and for the selection of the therapy may well be what we may want to propose and consider. Because but before today, I discussed this morning with my colleagues in how many cases we really need to go for this right heart catheterization in order to, in general practice, to initiate the therapy and go further. Do you really believe that this is for everyone? But, or in around 20%, as Marco is saying, different phenotypes, we have therapy for this and that. So why not to challenge this a little? Because I'm sure that you guys have a lot of experience.
I think the Philip group, will do this. But so what we are saying is, if there is a precapillary component, the patient is less likely to benefit from TR correction. If the patient has a postcapillary hypertension, so if he has HFpEF, and maybe we should add, if there is ventricular interindependence, these patients have a high likelihood to benefit from transcatheter intervention because they have this TR HFpEF phenotype in some way. So it can be used in this way. If a patient doesn't have left ventricular diastolic dysfunction, if it doesn't have post-capillary hypertension, maybe the intervention is more prevention of development of HFpEF than real immediate benefit. So there are three scenarios that can be depicted based on right heart catheterization. I don't know if Philip and Carl Patrick agree.
Well, I'd say that as soon as you have made the decision that you want to treat somebody and treat the tricuspid regurgitation by transcatheter means, I think that it's certainly worth the investment and also do the right heart cath. I'm not saying that you have to do it in everyone to make a decision whether TR needs to be treated. But maybe one additional comment is, why did we go through all that meticulous analysis? And the reason was that before there was the question whether if you treat TR and increase pulmonary artery forward flow and also venous return to the left side in patients who have high LV filling pressures and have diastolic dysfunction, will we actually make things worse? And that was a serious concern. And we said, no, we won't make it worse because we will improve left ventricular filling pressures by more favorable ventricular interaction. And I think that in most cases, this is actually what can be seen. Despite the phenotype TR and HFpEF, when you treat TR, you can actually reduce LV filling pressures, despite the fact that we fill the LV more than before. And I think that's important to know, because there's still many are concerned to treat TR in HFpEF, but it is better for filling pressures and not worse.
And then there are the patients with the MR that maybe may worsen. It's a different story.
So,
That's a different story. That's a different story.
Yes.
Marco, with the next presentation. So we'll see what is the role of imaging with echocardiography. So Marta, please.
Thank you, Mariana. So we are going to present first the patient, very similar to what has been shown before, 79-year-old female with history of long-standing arterial hypertension, persistent atrial fibrillation since several years ago, that comes to our hospital with fatigue and with very typical signs that you will immediately recognize with leg edema and this erythromelalgia. And also she shows in the blood test some renal insufficiency and this very high elevated pro-BNP. Routine baseline echocardiography at the emergency room shows this non-dilated hypertrophic left ventricle with preserved ejection fraction, has mild MR, and normally functioning aortic valve. But as you can see here, there is significant tricuspid regurgitation and also of note, severely dilated of both atria, and also some dilatation of the right ventricle. Again, here we apply the clinical scores for heart failure diagnosis that have been previously mentioned, and according to both of them, to two of them, the probability of this being a HFpEF is almost 100%, 95 to 100%. So what should be the next steps in this typical lady presenting to our clinic? What's the role of the imaging in this setting? So our role is to precisely diagnose tricuspid regurgitation in the setting of a patient who presents with HFpEF. And for that, we need to answer several questions, which include the quantification of tricuspid regurgitation, the phenotyping of this tricuspid regurgitation, quantifying right ventricular function, and if we are planning some procedural or just to approach, if we need to intervene these patients according to the previous questions, we need to do a detailed analysis of the anatomy of the tricuspid valve. For that, we will use several imaging techniques, but mainly we can squeeze a lot of the information we got in transthoracic echocardiography, but we have also combination with transesophageal echo, cardiac CT, and also, in some cases, cardiac MR. Let's go to the first question. Quantification of tricuspid regurgitation can be very complex. Typically, we want to detect those patients with severe tricuspid regurgitation in a 3-grade scale. And if we are planning procedure, particularly transcatheter procedures, we will further divide that severe tricuspid regurgitation in more granular advanced stages of tricuspid regurgitation. Is there a holy grail parameter that tells us this is severe tricuspid regurgitation? No, we use a multi-parametric approach, but we have kind of echo red flags that alert us that we can be in the presence of severe tricuspid regurgitation, as you know, and this is mainly defined by the vena contracta width, which is a very simple parameter that we can obtain even in the emergency room with a transthoracic echocardiography, and even a simple PISA radius of more than 9 millimeters. If we adjust the Nyquist limit, we can get it. Of course, more academically and later on with a more comprehensive approach, we can estimate the regurgitant orifice and also the regurgitant volume. But very simple things, continuous wave Doppler on the regurgitant flow showing a very early peaking velocity, showing rapid equalization of pressures between the right ventricle and the right atria, and indicating severe tricuspid regurgitation, and just lowering the baseline color Doppler shift down to get a Nyquist limit around 25 centimeters per second, showing a nice vena contracta, as you can see here in the slide, and measuring a PISA to further then calculate and estimate regurgitant orifice. Second question, what's the etiology or the phenotype of this tricuspid regurgitation? You know that currently we are talking about primary organic tricuspid regurgitation, those that are related to intracardiac leads, and particularly in the setting of HFpEF, we are talking about secondary tricuspid regurgitation that at the same time can be from atrial or ventricular origin. Typically in HFpEF, we typically find more atrial TR as discussed before, but we can find overlapping forms of secondary tricuspid regurgitation. Let's go back to our patient, how we characterize. Of course, medical records are important, and also analysis of the valve anatomy. In this patient with atrial fibrillation, long-standing persistent atrial fibrillation, dilated atria, we could think of an atriogenic secondary tricuspid regurgitation, but we measure also the annulus, that it's, of course, very dilated in these patients with very dilated atria. Remember that the atria depends, the annulus size depends a lot on the atria. And also that was very dilated in this patient. Second, after quantification, phenotyping, TR, we go to right ventricular function status. And this might be sometimes, as you know, challenging, particularly in patients with volume overload. That motion of the right ventricle can be overestimated by simply relying on ejection fraction. First important point, and I'm going back to very basic transthoracic echo that can be squeezed and give you a lot of information. Please use the focus right heart chamber view on the transthoracic just by tilting your probe anteriorly and laterally from the regular conventional apical four-chamber view. And there you can include the free wall of the right ventricle and all the size, all the chamber of the right atrium. From there, you can apply several methods. Again, as for quantification of regurgitation, we don't have a single parameter, but we have, fortunately, many parameters that we can combine. We can look at the strain of the free wall. We can look at the size. We can look also at 3D echo. Even with transthoracic 3D echo, volume measurement of the right ventricle is still difficult, but it's improved by automatic algorithms, and particularly on AI-based algorithms, and a simple, very simple parameter that gives us a lot of information. Don't forget the subcostal view in a simple transthoracic echo, looking at the vena cava, its dynamics, and also flow reversal in the hepatic veins. So very important to look and to see the hemodynamic impact of this tricuspid regurgitation. In case of doubts, in some patients, we can go to more comprehensive and complementary, ideally the gold standard imaging technique to measure right ventricular function, which is cardiac magnetic resonance. Fortunately, recently we had data coming from small studies, more than 300 patients, that depicted some prognostic values of right ventricular end diastolic volume, specifically in patients with tricuspid regurgitation, with indication of bad prognosis among those patients who show an end diastolic volume of the right ventricle larger than 150 mL per square meter of body surface area. And that parameter predicted the need of hospitalization due to heart failure and also mortality. So this may be, if confirmed, used as a point for indication of intervention in these patients. Also to look at right ventricular function and trying to have a double objective. On the one hand, trying to unmask latent right ventricular dysfunction in the presence of volume overload, as said. This sometimes is difficult just by relying on volumetric approaches or even in strain approaches, because all are load dependent. And also with the objective to kind of predict how the right ventricle is going to respond after we release the volume overload. And that's a potential role of stress imaging, particularly with stress echocardiography. There's some work done in patients with pulmonary hypertension, not specifically TR, that show a prognostic value of ejection fraction during exercise above 38% as a threshold for also a prognostic threshold in patients, as I said, with pulmonary hypertension. But there is a scarce data or non-published data on patients with isolated or in the particular scenario of HFpEF with tricuspid regurgitation. Finally, if we think that the patient has severe tricuspid regurgitation that could potentially be treated and that could help in the treatment of these patients with HFpEF, we have to go further analysis of the detailed anatomy of the tricuspid valve. And for that, we mainly rely on transesophageal echocardiography and cardiac CT. Transesophageal echocardiography with two main analyses, one at the right ventricular inflow-outflow view with the orthogonal view in the X-plane or biplane views, where we have all the swept of the tricuspid valve from anterior to posterior, from septal to lateral, and with concomitant images with flow imaging that gives us precise information on the leaflet motion, leaflet length, on the jet origin, and also on the coaptation gap. Second, in TE, with advanced imaging, also having information from the short axis transgastric view or the 3D EMPHASE view, where we can see the whole anatomy of the tricuspid leaflets, its motion, again, the coaptation gap, and also with color Doppler flow imaging, the origin of the jet. With that, we can have a good idea of what's the underlying mechanism and then establish the best strategy to treat these patients with a specific device or a specific intervention. Finally, CT also is essential for this detailed anatomical study, particularly if we are planning transcatheter annuloplasty or transcatheter replacement for the sizing of the device, and also to look at the subvalvular apparatus and the relationship of the subvalvular apparatus with the leaflets, as well as it can be of help in assessing the relationship with leads in patients who are wearing intracardiac devices. So as take-home messages, I would like to highlight the role of imaging in patients with HFpEF and tricuspid regurgitation phenotype. This is important, and we have to think of this when we face patients with HFpEF, because as mentioned before, there is a synergistic pathophysiology and a potential cause or concomitant aspect to be treated. So our role with imaging is to diagnose these patients, answering to the questions of how severe is this TR, how's the right ventricle status, which is the phenotype of this tricuspid regurgitation, and what's the detailed anatomy of this valve. For that, we have an integrative comprehensive approach of using transthoracic echocardiography. Don't forget it, can give you a lot of information and can raise the red flags with a PISA larger than 9 millimeters, vena contracta more than 7 millimeters. Always remember the focus view on the right heart chambers with transthoracic echo. Maybe we already have some thresholds for end diastolic volume obtained by cardiac magnetic resonance, 150 mLs per square meter of body surface area. It's an indexed volume. And finally, when we think that treatment can be a potential option, particularly approaching transcatheter therapies, think of transesophageal echo, cardiac CT as a complementary role to really be precise defining the anatomy of that particular tricuspid valve. Thank you very much for your attention.
Thank you very much, Marta. We are a little bit out of time, so I just introduce Marianna Damo that will talk about the treatment options. Marianna, the floor is yours.
Treatment options, medical therapy, we already mentioned about this, surgery and transcatheter. So regarding medical therapy, Mark already showed these indications from heart failure guidelines where we have diuretics for decongestion, SGLT2 inhibitors, and treatment of comorbidities, and probably in the near future we'll have other drugs to treat HFpEF. So medications are mainly therapies for HFpEF. Treatment of comorbidities is crucial in patients with HFpEF, and we can have different profiles, different phenotypes. TR is one of these profiles that need to be treated. And this is the paper mentioned by Piotr, where we found a high rate of HFpEF patients among patients with TR. In patients with TR, treatment of HFpEF is advised. But there was one question in the chat regarding the role of SGLT2 inhibitor in these patients. What should we expect from SGLT2 inhibitors? There is no data regarding the effect of SGLT2 inhibitors on TR reduction. What does this mean? That probably these treatments should be concomitant rather than one after the other. And we only have data for SGLT2 inhibitors for REF, but not for PEF. And if we look at the TriLuminate trial comparing TriClip versus medical therapy alone, if we look at the control group, you can see that only a minority of patients, about 5%, underwent improvement of TR severity after medical therapy only. And the TR is also a marker of persistent congestion at discharge after hospitalization for heart failure. And we know that in the initial phase of the disease, patients need low doses of oral diuretics, but in an advanced stage of disease, they can develop diuretic resistance. So it's crucial to intervene at an early stage. Surgery, we know that these data are for isolated TR, and probably there is debated the nomenclature isolated, but this group of patients probably include also patients with HFpEF. Mortality is high because patients in an advanced stage of disease were included in this study. But if we stratify patients at lower risk can be good candidate for surgery. And if the tri-score is less or equal to 3, you can see that the survival after surgery is really better than other treatment options. Regarding transcatheter transcatheter, we have many devices to treat the tricuspid valve. We have edge-to-edge approach, we have replacement. I don't want to go into details, but just to remind you, as already showed by Marco, that patients included in studies evaluating safety and efficacy of these devices are mostly patients with TR HFpEF phenotype. So all the patients, female, hypertensive with atrial fibrillation and preserved ejection fraction. These are the results of the TRILUMINATE to 1 year that all you know, but the new is this result at 2 years. So we finally have a separation of the Kaplan-Meier curves in terms of heart failure hospitalization in favor of the device group as compared to the control group. So finally, a starting point to think that TR has a crucial role in the progression of the disease in patients with TR. And these are data from TRIFR, but we don't have time, and these are for TRISCIND, so showing basically an advantage in terms of patient-reported outcome, and these are data from the real world, published by Philip Lurz and colleagues, where you can see that the intermediate stage of disease is probably that timing point where we have to work with the transcatheter approach, and with this disease stage approach based on ejection fraction, RV function, renal function, and NT-proBNP. So to conclude, we have to evaluate and we have to manage patients with HFpEF and TR, trying to take into consideration not only HFpEF and TR themselves, but also all the other comorbidities around, so AFib, obesity, and hypertension, for example, and then treat HFpEF for sure with medications indicated in guidelines, but also think about treating TR with an invasive approach, because this can have a negative contribution to the heart failure progression. Thank you for your attention.
Thank you so much, Marianna. I wonder whether there are additional questions. I have, but we have just 2 minutes. We talk about TR in heart failure, and we know that there is atrial and ventricular secondary TR. Are all the things the same or not? When we see atrial secondary, so in HFpEF, do we have just atrial secondary TR? I think yes, because the ventricular function should be normal. And what about the results, Marianna, Philippe, Carl, Patrick, of the procedure in the different forms of TR? Atrial, ventricular, with HFpEF, with HFrEF, with atrial fibrillation?
Please, Philippe.
I mean, the results in atrial TR are certainly better, and they're also more durable because there's less tethering, and overall it's probably considered an earlier stage than once you have severe remodeling and dilatation and tethering of the RV. And then in the question whether it's just atrial TR plus or minus HFpEF, well, as long as there is ventricular interaction which can be optimized, then you'd be surprised about the dramatic symptomatic benefits these patients have. And it can be even higher in those with HFpEF than in those patients with sole atrial TR without any increase in LV filling pressures. Although having said that, almost everyone with atrial TR also has some degree of HFpEF.
Philip, one for my curiosity, if I may ask you the question, not really related to underlying pathophysiology and phenotype. Do you really believe that at that stage we can make any kind of recommendation based off TRILUMINATE trial, even with 2-year follow-up reports? At that stage, shall we opt as a group of heart failure specialists, interventionists for really randomized clinical trial with a long enough follow-up to make sure that that we are able to prospectively identify those factors which may predict the response and also validate whether this procedure helps, or you are, as interventional cardiologists, 100% convinced that it works well in selected patients?
Okay, to give you a short answer to this, first, this is extremely early stage, and it is really rare that in an interventional field we have randomized data at that early stage. And remember that also for the intervention, there is still a certain learning curve, so we will get better. Secondly, yes, scientifically, there aren't all questions answered, but now we have some signals also in respect to hard clinical endpoints, in addition to the very robust improvement in KCCQ seen across all studies. And then thirdly, and this is not scientific, this is just my clinical experience, whenever you manage to reduce TR significantly, patients come back, they're very happy, and they improve dramatically. It's just a clinical observation on a day-to-day basis, but obviously that matters also for me because I treat these patients, I see them coming back, and I see that they're doing much better.
Regardless of the severity of the clinical scenario, I know the time is virtually out because our initial experience 5-7 years ago is pretty bad because we aiming at the very late end stage and kind of a desperate action. That's what made us a little bit worried and concerned.
I mean, in general, we shouldn't treat them too late, as we know now.
No. So, I mean, key message is treat early. Look also at cardiac function, ventricular interaction, right ventricular volume overload, treat well, and I think that transcatheter option remains the first choice in most of the cases. I have to conclude. It's been a pleasure. I think we have had also food for thought for our brain. That's the reason why I like to do these things and to consider this topic. We have imaging, we have had pathophysiology, therapy and epidemiology before. So thank you very much for having attended. Thank you to this wonderful faculty that has been put together by mainly, I must say, by Mariana and with my small advice. But thank you, Mariana. Thank you, PCR. Thank you.